Yes. Good morning, everybody. Dr. Pradeep Srinivasan from the Refer series, Bangalore. Today we are going to see a complex cardiac anomaly. As you all know, the first section in fetal echo is the upper abdominal section. So here we have the left side of the fetus on the left of the screen and right side of the fetus on the right of the screen. After we have determined the left-sidedness and right-sidedness, then we look at the inner structures. You can see the aorta is on the left side, the IVC is on the right side. You can see that the aorta is immediately anterior to spine and the IVC is slightly more anterior to the spine. So this is the normal relationship of aorta and IVC. So the abdominal situs is normal in terms of vasculature. Also the liver and stomach had a normal anatomy. Then we move into the chest. The first observation here is in the four-chamber view, there is increased echogenicity involving the interventricular septum and also involving the right-sided AV valve. You can see that the AV valve shows thickening. That's the left atrium with the pulmonary veins entering the left atrium. This is the right atrium. The IVC entered actually the right atrium. So when we go up into the three vessel view, you can see the PAS. This is left, this is right, and the pulmonary artery is small, aorta is large, SVC is small. So there is a inverse relationship between the pulmonary artery aortic dimension. So now we try to proceed and look at what is the anomaly. We try to get the apex of the heart anteriorly and we are looking at a cine and we realize that not only the interventricular septum, also the free wall of the right ventricle and the tricuspid valve and little bit of the crux is all echogenic, and there are echogenic intracardiac foci in the right ventricle. So that is the observation in terms of echogenicity changes. Also you can see that the left ventricle size is normal whereas the right ventricle size is small. Then a freeze frame shows increased echogenicity as we just discussed in the right heart. The fetus has turned and we take the advantage to demonstrate the aortic arch, which seems to be normal in 2D and in color. Whereas the ductal arch I was not able to demonstrate properly. Then we waited for the fetus to turn. Once it turned, we again get the four-chamber view and the findings of a small sized RV and a normal sized LV is actually demonstrated here. The tricuspid valve area is completely abnormal and the left ventricular outflow tract shows a normal aorta, whereas when we try to show the right ventricular outflow tract, you can see that the pulmonary valve is constantly seen and is thick and echogenic. So that was the observation with the pulmonary valve. Ascending aorta, however, was normal. Color across the ascending aorta is normal and descending aorta was normal. Then because the RVOT showed a rigid pulmonary valve, we're trying to do a Doppler across the pulmonary artery. So you can see that antegrade flow is not there. There is actually reversed flow in the pulmonary artery. So this is a pulmonary valve atresia with no antegrade flow across pulmonary artery and a reversed flow in the pulmonary artery from the ductus. The ascending aorta shows normal antegrade flow with a velocity of 93, which is normal. That's the SVC, right atrium, IVC, that's the hammock view, which is normal. This is the LVOT view. That's the interventricular septum, that's the anterior wall of aorta, that's posterior wall of aorta, this is mitral valve, this is LV. So that's the LVOT view. When we have the RVOT view, you can see that the pulmonary valve is sort of immobile and not opening, and it is thickened and echogenic, and this is the main pulmonary artery. That's again the reversed flow in the ductus arteriosus. The 4-chamber view now shows a normal LVOT, and now we start finding that there is a large VSD. So you can see here that this is the left ventricle, this is the right ventricle, that's a large VSD, and that's a large VSD, and you can see the right and left ventricle are communicating across. This is the crux of the heart. This is the septal mitral valve. This is the septal tricuspid valve. So now this is the large ventricular septal defect. That's the left ventricle, that's the right ventricle, and that's the communication. So you can see in the crux we have a normal apical insertion of tricuspid valve, normal basal insertion of mitral valve. So this is the normal offset which is visible. So the crux is normal. Further, when we do the color Doppler across the 4-chamber view, you can see this is the LA, that's the LV, this is the mitral inflow. On the right heart, we did not see a normal inflow. So then from the LV, you can see the aorta coming outside, and then the great vessel crisscross is visible. So when you look at the inflow, it is in red. The outflow LV is in blue, but you can see the outflow in pulmonary artery is also, it's not in blue, but it is in red. So there is a reversed flow in the pulmonary artery from the ductus arteriosus. So that is the observation in the outlets. So the main pulmonary artery, because it is not receiving blood from the right ventricle, it is receiving blood from a reversed fashion from the ductus arteriosus. So this is the 3-vessel tracheal view, and in the 3-vessel tracheal view, this is the ductus arch, this is the aortic arch. So the ductal arch, you can see, should have been in blue, it is in red. This is a momentary red in the aortic arch, but this is a continuous red in ductal arch. So there is reversed flow in the ductal arch from the distal duct to the proximal duct and pulmonary artery. So this is a duct dependent circulation. Because the pulmonary valve is atretic, no blood is coming from RV into pulmonary artery. Blood is coming in a reversed fashion from the distal aorta across the V confluence in a reversed flow into the ductus arteriosus and pulmonary valve. Now this is the LVOT in blue, which is antegrade flow, normal flow. So this is the 4-chamber view, and you can see the color abnormality. This is LA, LV, flow across mitral valve in red. Whereas you can see flow across tricuspid valve. You can see the dimension of the open mitral valve is so wide. The dimension of the open tricuspid valve is narrow. So the tricuspid valve is also dysplastic and hypoplastic. Next, you can see that when left atrium pumps into left ventricle in red, the right atrium is actually getting a reversed flow. So this is the regurgitant jet in blue. So mitral flow is in red, tricuspid flow is in blue. So there is a reversed flow in tricuspid valve. Then we have here a VSD, which is showing blood flow from LV into RV. So this is the flow from LV into RV. So the RV actually is not receiving much blood from tricuspid valve, but it is kept open and patent by flow from LV to RV across the VSD. This is the flow across the fossa ovalis. So you can see fossa ovalis blood is from from right atrium to left atrium, whereas the VSD flow is from left ventricle to right ventricle. So that's how the right ventricular lumen is kept patent. So this is again a 4-chamber view showing only flow from LA to LV. Now when we look at flow across tricuspid valve, so we saw a small opening, and now this is the large regurgitant jet. You can see this is blue. So flow from RV into RA as a regurgitant jet reaches the roof of the RA. That's the large tricuspid regurgitation. Now we can see the reversed flow in the ductus arteriosus, antegrade flow in the aorta, reversed flow in the ductus arteriosus in this loop. So that's the reverse flow in ductus arteriosus. Now we do a Doppler across the tricuspid valve. You can see that it is thumping and it does not have the two normal peaks of E and A. It's a single peak and it is abnormal. Now we see the aortic valve. It's a normal Doppler across the aortic valve. Again we try the tricuspid valve. It is abnormal waveform. When we move the sample box across the tricuspid valve from lateral to medial, then you start getting a little normal E and A waveforms only at this point, and also at that point you start getting a huge tricuspid regurgitation. You can see velocity of 210 centimeter per second. So when you do atrioventricular Dopplers, we'll have to keep the sample box and we have to dynamically move the sample box across the width of the valve but events can be captured because it's flow sensitive and the location sensitive. Only in right position you will get the regurgitation, because when you kept the valve when you kept the sample box little laterally, there is no regurgitation. When you move the sample box little medially, there is a large regurgitation. So that's a tricuspid valve dysplasia with less opening and a large regurgitant jet. So now we are scrutinizing the 2D abnormalities of the valve. You see the mitral valve is opening nice and wide, whereas the tricuspid valve is moving and opening very little. Also the tricuspid valve is echogenic, the interventricular septum is echogenic, the free wall of the right ventricle is also echogenic. So probably there is also secondary endomyocardial fibroelastosis. Now that's the LV chamber dimension 5.5 mm normal. That's the RV chamber dimension 4.5 mm small, and LA and RA show 6 and 5, which are normal in millimeters. And this is the ductus arteriosus reversal, which has been sampled. It's a high velocity reversal. That's the 3-vessel tracheal view showing antegrade flow in arch of aorta, retrograde flow in ductal arch. And that is again the 4-chamber view and the 3-vessel tracheal view showing the events which we just described. Also in this 3-vessel tracheal view, you can see the right branch pulmonary artery. You can see this, that's the right branch pulmonary artery. So the reverse flow in the duct is actually maintaining the flow into the lungs, which is an important point to be noted. So in this 4-chamber view, you can actually see that's the LA, LV, wide open mitral valve. That's RA, RV, narrowly open tricuspid valve. The red is inlet taking blood from RA to RV. The blue is the regurgitation taking blood back from RV to RA. So those are the events, and this is the large regurgitant jet. The jet reaches the roof of the right atrium. And this 4-chamber shows all the hemodynamics across both the valves. So this is LA to LV, that's LV to RA across VSD. This is RA to RV, and this is RV to RA jet. And this is fossa ovalis flow from right atrium to from left atrium to right atrium. So the last video showing the events of the outlets with the great vessel crisscross and the tricuspid valve regurgitation as we just described. And this is the large regurgitant flow in the ductus arteriosus hitting the pulmonary valve and supplying the lungs. And that's the pulmonary artery dimension, which is slightly smaller, and this is the pulmonary valve which is not open. That's the aorta, which is larger and normal. So then now we have the dimensions which we have taken as part of the calculation. So you can see here we have done the ascending aorta dimension, pulmonary artery dimension, left atrium, right ventricle dimensions in millimeters. Then we have taken the main pulmonary artery velocity. We have taken the ascending aorta velocity. We have taken the mitral valve E by A ratio, tricuspid valve E by A ratio. That's the TI index, which has got the isovolumetric contraction, ejection time, isovolumetric relaxation, and the myocardial performance index. We have done the fetal heart, atrial heart rate, ventricular heart rate. Also, we have looked at the Z scores of the ascending aorta, pulmonary artery, chambers, etc. So that completes the fetal echo in terms of morphological 2D analysis, color Doppler analysis, pulsed wave Doppler analysis. So this is a case of pulmonary valve atresia resulting in small right ventricle with endomyocardial fibroelastosis, also having a tricuspid valve dysplasia with a smaller opening of tricuspid valve and a large tricuspid regurgitation. The right ventricular hypoplasia is there, but the RV is kept open because of the flow across a large VSD from LV to RV. So this is a case of severe right ventricular hypoplasia with abnormal pulmonary valve, abnormal tricuspid valve, and probably secondary endomyocardial fibroelastosis of the RV. So the prognosis in this case will be eventually a single ventricular morphology, and repairs may need to be in multiple stages. The good thing is ductus arteriosus is kept the pulmonary vasculature open in spite of pulmonary valve atresia. So this is a duct dependent circulation. The bad thing is the echogenic changes in the free ventricular wall, in the ventricular septum, in the tricuspid valve are all evolving abnormal changes of the myocardium, endomyocardium, which may result in failure of the heart to pump well. So this is about this fetal echo at 18 weeks of gestational age. Rest of the anatomy was perfectly normal. We have suggested pediatric cardiac consultation and also advised for amniocentesis and chromosomal microarray. Now we will look at, once you have done this, how to counsel the patient and how to make them understand. And I will show you the counseling sheet and drawing in a short while. So this is how we counsel the patient. Now we can see that this diagram shows the cardia in a simple manner. Now this is right atrium, left atrium, right ventricle, left ventricle. Now in this patient, the SVC, IVC flow into right atrium. There is veno-atrial concordance. Foramen ovale appears normal. The pulmonary veins enter into left atrium. So LA is normal. So in the 4-chamber view, you can see that the RA, LA, LV are of normal size. RV you can see is severely small. So this is a hypoplastic RV. Then you can see the tricuspid valve here is abnormal. So it is small. So you can see there is tricuspid valve dysplasia, small opening. So the inflow from RA to RV is very less. And there is a large regurgitation. That is what is shown here. As a result, less blood comes into RV. RV is extremely small. It is kept patent by the VSD. So blood from LA goes into LV across normal mitral valve and from LV into RV across the VSD, keeping the small RV patent. From RV you can see that there is a smaller pulmonary artery and the pulmonary valve is atretic. So there is no flow from RV into the pulmonary artery or into the branch pulmonary arteries. However, from the aorta across the ductus arteriosus, blood flows from aorta to pulmonary artery in a reversed manner. So this reversed flow is what keeps the blood going into the lungs. Actually this has to land here. The drawing shows it here, but actually the duct will come here beyond the pulmonary valve occlusion. So the branch pulmonary arteries in this patient were patent and they were receiving blood from aorta in a reverse manner across ductus arteriosus into the lungs. So also the RV had multiple echogenicities with thickening of the tricuspid valve, increased echogenicity of the interventricular septum and also free wall. So this will help the patient understand what has gone wrong and acceptability becomes easier Also, this will help the pediatric cardiologist and cardiac surgeon to understand what we are trying to tell them. So thank you very much for a patient hearing. This is Dr. Pradeep Srinivasan from the Refer series from Bangalore. Happy learning. Jai Hind.